Hello everybody. I'm Malhaz Mizandari, radiologist from Georgia. I work at Tbilisi State Medical University. Tbilisi is the capital of Georgia. Today we'll have a talk about the Wirsung duct interventions which we perform under ultrasound guidance. So, ultrasound in Wirsung duct percutaneous interventions. Let's review some anatomy. As we remember, the pancreas is located deep in the body in the retroperitoneum, just anteriorly to the major vessels and posteriorly to the stomach. So, as you see here, it's a horizontally oriented and slightly oblique position, having pancreatic head more caudally and tail more cranially. This is actually the Wirsung duct, how it joins the CBD and joins the papilla of water. Today we'll have a talk about the interventions on Wirsung duct, which travels in the mid portion of the pancreatic tissue. Here we can see the anatomic cross sections, and this is the most caudal one. You see here just the uncinate process. This is the pancreatic head. You see here the portal confluence and splenic vein. When we go slightly upwards cranially, we can see the whole pancreatic body, and finally in the most cranial portion, most cranial cut of this anatomic images, you can see the distal portion of the body and the pancreatic tail, which reaches the spleen. If we take the sagittal cuts, and this is the pancreatic head lying anteriorly to on the anterior surface, touching the anterior surface of the wall of IVC, and you can find here on a small area where we have small gap to reach the pancreatic head, but it's not good to assess the pancreatic duct here because it's the very distal portion of it. If we go slightly, to the left, you see here the aorta, celiac pointing to the pancreatic body, and you can see here the bowel, large bowel, and this is the stomach. So actually no SS is seen here. If we go more left, you can see here the pancreatic body, or the proximal portion of the tail, which and you can see here the kidney and stomach again, and we take most left cut and the sagittal cut, where we start seeing spleen and small portion of pancreas here. So seems like there is no possibility to approach the Wirsung duct from taking in consideration these anatomic slides. So lecture is about Wirsung duct interventions under ultrasound guidance. So what should we do? Should we stop at this point? Because no. We should keep in mind the normal anatomy variants, which are not rare. Sometimes pancreas is located just behind the left lobe, posterior surface of the liver left lobe, which enables to reach it using transhepatic approach. In some cases, we can see pancreas immediately after anterior abdominal wall, so it makes it possible to assess it percutaneously. Of course, we should keep in mind that anatomy may change due to presence of some pathology like pseudocyst or necrotic pancreatic fluid collection, which can interrupt the anatomy and push away the stomach and bowel and enable us to assess the pancreas. And finally, you should not exclude the transgastric route of Wirsung duct SS. What are the indications for Wirsung duct percutaneous SS? Of course, it's Wirsung duct dilation, if it's manifested clinically and cannot be managed conservatively. What might be the cause of this? So it might be due to pancreatitis, when swelled pancreas stops the Wirsung duct, or Wirsung duct calculi. It might be due to pancreatic head tumor, or some extrinsic factors like CBD calculi, retroperitoneal tumor, lymph node package, etc. What is the aim of such intervention? I mean intervention on Wirsung duct. First of all, we decompress the Wirsung duct performing such intervention. We can eliminate the clinic of pancreatitis. We prepare the patient for Wirsung duct patency, possible percutaneous restoration. So we can plan the restoration of Wirsung duct patency, which might be performed percutaneously. Pancreatic imaging. Of course, we know the pancreas might be imaged in ultrasound, on CT, MR. Of course, CT, MR are much more informative in pancreatic imaging, but ultrasound is great for intervention guidance, and this is the critical in this situation. Why is ultrasound the imaging guidance technique number one? We have several reasons to say so. First of all, it's very quick. It's not connected with ionizing radiation. It's real-time technique, and with same time we can include not only have the B-mode image, but see the vessels in real time. We can aim and guide the needle in real time. We have possibility to perform the procedure in any inline oblique plane, which sometimes it's very important. It's cost-saving technique, and of course it's possibility of combination with fluoroscopy. So because of these big advantages, ultrasound is very useful. This is equipment, very simple equipment, which we can use for such procedures. This is ultrasound unit, C-arm unit, and operating table, which moves from the ultrasound area to the fluoroscopy area. You can see here the probes which we usually use. It might be also the linear array for freehand technique. When we use the convex, we almost always use the needle guide, which adapts, which has adapters, which accepts the different diameter puncture needles, and this is the set for drainage. This is the guide wire drainage set. You see here the puncture needle, which accepts this guide wire, according which we insert the drainage catheter in the target. More and more we use now special sets, 22 which contains 22 gauge Chiba needle for safe access. You see here very nice picture, very nice ultrasound image of normal pancreas. We see here the anterior abdominal wall, a little portion of the left liver left lobe, and you see here all the way across the anterior, along the anterior surface of the pancreas, you see the stomach, anterior and posterior wall. So in this case, it will be difficult to assess the Wirsung duct without in this patient, without penetrating the stomach. But this is the same areas, again, anterior abdominal wall, portion of the left liver lobe, and anterior surface of pancreas, and you can see that there is nothing between the liver and pancreas. In this case, we can assess the pancreatic tissue, Wirsung duct, avoiding the stomach. Some cases with pancreatic duct, Wirsung duct dilation, this is due to pancreatitis. The swelled pancreatic head stops the Wirsung duct here. Because of this, it's dilated. In this case, the Wirsung duct dilation is caused by calculus, and you note that there is nothing between liver posterior surface and pancreas. No stomach is seen between them. In this case, you see the dilated, this is the CT image, dilated Wirsung duct. We placed the CBD stent to this patient. As you see here, it seems like it's difficult to assess the Wirsung duct without penetrating stomach. This is one more case with severely dilated pancreatic duct due to acute pancreatitis, and you see anterior and posterior walls of stomach located anteriorly between pancreas and anterior abdominal wall. Now I'd like to present some cases which can show the possibility of ultrasound in Wirsung duct intervention. This patient had acute pancreatitis. Patient presented with severe pain and dehydration due to nausea and vomiting. Necrotic fluid collection was detected in pancreatic head area. Patient had mechanical jaundice, so the necrotic fluid collection stopped the CBD, and severe dilation of Wirsung duct has been detected. What kind of procedures we performed to him? It was PTC was done. We performed cholecystostomy. Necrotic fluid collection drainage has been performed to him, and finally we did transgastric wirsungostomy. You can see all those procedures in real time. This is the gallbladder. We assessed it by percutaneous puncture. We are injecting now the contrast. Finally, pigtail catheter is placed in the gallbladder. Now we assess the pancreatic head necrotic fluid mass, which is opacified after the catheter placement, and we rinse it on the ultrasound guidance. We see we are injecting saline and aspirating it back. And finally, we perform to this patient wirsungostomy. You see here is the anterior and posterior walls of stomach, and this is our puncture needle. By the way, the stomach creates the problem for puncture, causing the change of direction of the needle. You see how needle changed the direction. This is the needle guide, and it's out of this trace. So we needed to withdraw the needle and to perform it a second, or probably third time also. This is the tip of the needle. It looks like it is in a Wirsung duct, but we should to get content of pancreatic juice in it, so we are sure that we are in correct place. Finally, we succeed to puncture the Wirsung duct. We place the drainage catheter, and you see now fistulography. We inject the contrast, which opacifies the whole Wirsung duct, and when we create the pressure, it can also reach it can also contrast reaches the duodenum. So this is post-procedure CT of this patient. You can see here the drainage catheter, which passes through the anterior abdominal wall, passes the anterior and posterior walls of the stomach, and it's placed in the Wirsung duct. This is the 3D reconstruction. You see the PTC catheter located in gallbladder. You see the Wirsung duct drainage catheter, and this is the catheter which was placed in necrotic fluid collection due to pancreatitis. When we inject the contrast in the PTC catheter, you can nicely depict all the anatomy of the biliary tree with the problem here very distally, and this is the image when we injected the contrast through the wirsungostomy catheter. So, results of our intervention: no procedural complications were observed. Clinic of acute pancreatitis eliminated and patient's general condition improved dramatically. Subsequently, patient underwent a successful surgery. The second patient with unresectable malignant block of Wirsung duct and biliary tract also. PTC with subsequent CBD stenting has been performed to this patient 8 months ago, and then he presented with abdominal pain irradiating in back, nausea and vomiting. Duodenal obstruction has been excluded by CT with oral contrast. Wirsung duct was dilated, enzymes elevated, so the manifested clinical findings were due to pancreatitis. So what kind of procedures were performed to this patient? First of all, we drained the Wirsung duct, and after this, Wirsung duct percutaneous endoluminal RFA and stenting has been performed. This is the CT image. We'll see here the oral contrast which enabled us to exclude the duodenal obstruction. In this picture, we can see that looks like we cannot avoid the stomach for this puncture, but due to possibility of imaging in any oblique plane by ultrasound, we managed to avoid the stomach using ultrasound guidance for puncture. This is the procedure of Wirsung duct RFA and stenting, which was performed in 2 weeks after wirsungostomy procedure. You see here the pancreas with no dilation, no Wirsung duct dilation, and now we inject the contrast. You see here the stent, metallic stent. This is PTC catheter, and we inject the contrast via wirsungostomy catheter. Then we advance the guide wire. We withdraw the drainage catheter, and now we are trying to conduct the guiding catheter, guide wire, and then guiding catheter into the duodenum. So we were successful. We have to document it, injecting contrast that we are in correct place and that we haven't penetrated the Wirsung duct. And now we are advancing the RF device. Note these tiny electrodes. This is bipolar RF device which can process the block. We apply RF energy, and then we finally, after RF processing, we put the 6 mm balloon expandable stand, which is expanded in the distal portion of Wirsung duct. You can see this process in real time. So this stand is expanded. Then we withdraw the balloon, replace the drainage catheter, and perform the fistulography to document the restored patency of the Wirsung duct. You can see now how we inject the contrast, which reaches immediately without any problem the duodenum. You can see that all the way proximally the restored the Wirsung duct, the patency of which has been restored. So, results. Again, no procedural complications were observed on the wirsungostomy or after wirsungostomy procedure and subsequent RFA processing and stenting. Clinic of pancreatitis has been eliminated immediately after wirsungostomy procedure. Patient died with patent biliary and Wirsung duct stents in 4 months after Wirsung duct RFA and stenting. The next patient had acute calculous pancreatitis. Patient presented with abdominal pain, nausea, vomiting. Patient was dehydrated in a very poor general condition. MRCP revealed swelled pancreas and dilated pancreatic duct with some defects of filling in it, so we suggested the presence of stones, and ultrasound revealed wirsungolithiasis. So what kind of procedures we performed to this patient? First of all, we do wirsungostomy. We assess the Wirsung duct and drain it, and then we perform the procedure which I named Percutaneous Wirsungolitholapaxy. Actually, we decided to evacuate the stones in duodenum from Wirsung duct using wirsungostomy fistula. We performed it percutaneously, and it was performed 2 weeks after the wirsungostomy. This, you can see here the MR picture. This is swelled pancreas with dilated Wirsung duct. MRCP revealed the dilated Wirsung duct with some defect of fillings here in the mid portion and the distal portion, which were due to, happened to be due to stones, Wirsung duct stones. We performed wirsungostomy, and this is the CT after wirsungostomy procedure. You see our drainage catheter without contrast. It's without contrast. You see the drainage catheter here, pigtail catheter, a lot of stones located in the distal portion of the Wirsung duct, and one stone in the mid portion, and a lot of calcifications or embedded stones in the tail of the pancreas. When we inject the contrast, you can see the Wirsung duct, the whole Wirsung duct, and you can see how contrast reaches duodenum, and there is no connection with biliary tree. So as the patient became stable, we decided to try to push down all the stones. You see these are defects of filling due to stones. Push down all the stones into the duodenum, and we decided to perform it using balloon dilation. You see the dilated balloon in Wirsung duct, and this is the post-procedure image showing 2 ducts which are connected directly with duodenum. You can see this process in real time. You can see here the half-inflated balloon, and note how we are pushing down into the duodenum those stones, which are evacuated from here approximately. I show it again. These are the stones here, and you can see how we push them down from Wirsung duct into the duodenum. So this is pre and post procedure picture. Wirsung duct contains here the stones, and this is its connection with duodenum. But after the procedure, we are starting seeing another duct, which is also connected with duodenum. Actually, we made the dilation and Wirsungolitholapaxy procedure using this duct, which is probably Wirsung duct, and this is Santorini, accessory pancreatic duct. Post-procedure CT control. We did post-procedure CT control, and we found only 1 stone here. You see nicely it here. Unfortunately, we failed conducting this down because it sort of embedded into pancreatic tissue. This is CT control in 2 months, follow-up CT control in 2 months before we withdraw the drainage catheter. So we kept this catheter in the Wirsung duct in case of any problem, to have access, to have immediate access, to open it, and it was kept closed for 2 months. Then we performed the CT control, and we can see the patent Wirsung duct, and catheter was withdrawn. And this is the ultrasound follow-up in 3 months after catheter withdrawal. You can see the pancreatic tissue, no dilation, no Wirsung duct dilation, but still this embedded stone is in the very distal portion of Wirsung duct, or we can see that it's in the pancreatic head tissue. So results, no procedural complications, again, on wirsungostomy, and subsequent wirsungolitholapaxy were observed. Clinic of pancreatitis eliminated immediately after Wirsung duct drainage. Stones removal enabled to withdraw the drainage catheter, and patient is stable during 14 months after the catheter withdrawal. So I'd like to conclude that ultrasound is the best technique for Wirsung duct percutaneous assessment. Percutaneous wirsungostomy, including the technique of duct transgastric access, is a safe and effective technique. It should be suggested as a routine treatment option of acute obstructive pancreatitis. Combined ultrasound fluoroscopy guidance is the most efficient technique for Wirsung duct drainage. Percutaneous wirsungostomy enables to create a basis for subsequent duct patency restoration procedures, such procedures like stenting or endoluminal RFA&stenting or even percutaneous wirsungolitholapaxy. Thank you for your attention.